Initially, in terms of testing, we have performed 838,000, a little over that in tests total. It looks like system-wide, we have tested 471,374 people, and the positivity percentage of that is 17.3%. And at Baptist Memphis, we've tested 70,639 with a positivity rate a bit lower of 10.8%. So if you look at current hospitalizations, at Baptist Memphis, we have 89 people in acute care non-intensive care unit beds with COVID-19, and we have 42 people in the ICU for a total of 131, I guess, in the hospital right now with COVID. Of those 42 in the ICU, 33 of those 42 are on ventilators. And of the 14 new admits over the last 24 hours, only one was fully vaccinated. And in-house, there are 7 people in the hospital with COVID-19 who had been vaccinated. All the rest were unvaccinated. At Baptist DeSoto, there are 86 people in acute care non-ICU beds with COVID-19, and there are 18 people in the ICU with COVID-19. 12 of those 18 folks in the ICU are on ventilators, and of the 11 recent admissions there in the last day, one of those 11 have been fully vaccinated only as well. So the numbers are kind of staying where we've seen them in the low to mid 130s over the last few days, which is encouraging in that it's down from the 152 peak, but we'd love to see it decrease more. And it looks like we're still kind of in that hospitalization phase, even if we are, as some people have predicted, getting to the peak or just past the peak of the cases that we see. I think we're too early really to be terribly optimistic about that. We just have to wait for more information. What is concerning, though, is that you see a lot of people who are in the ICUs, and with 42 people in this building in the ICUs, that's a lot. When you look at ICU beds of 80 or so, we can expand a few, but that's a lot of people in ICUs because we still have other problems people need ICUs for, of course. And that's really been a bit of a concern on several accounts, just the availability overall. And it also would suggest that in some ways the Delta variant remains a bit more severe in what it does to people than what we saw with the earlier variants. And there's some new research on that that really, I think, bears that out, that Delta is probably twice as virulent and likely to cause severe disease and hospitalization as some of the other variants previously, Alpha and before. So obviously, we still see a dramatic majority of people who are unvaccinated. I have seen, I guess, a couple of deaths in total in people who are fully vaccinated. One fairly recently in an elderly person that doubled my rate from 1 to 2 of that unfortunate event. But obviously, still the dramatic minority of those cases are people that have been vaccinated. And then, of course, that kind of funnels into other issues with the booster shot. It may be that we could see a few more of those sort of build up over time without a booster, and that really is the reason that was predicted and why people really pushed ahead to move ahead with booster shots. So anyway, those are the numbers. Happy to answer any questions if anybody has any.
Hey, Dr. Threlkeld, it's Corinne. How are you today?
Hey, Corinne, doing okay. How are you?
I'm all right. I hope you had some rest over the holiday weekend. But I I think one of the things there's a lot for all of us to be concerned about right now, but I think one of the things we're all very concerned about is just this kind of continual rise in pediatric cases in particular. Do we have any sense right now of what is really driving that? Is it because children are a largely unvaccinated group? Is it because of back to school? Is it because the Delta variant is just so much more contagious? Or do we really not know why children are so affected yet?
I think yes on all counts. But no, in truth, I think there are a couple of things. Some of those factors were around before. There were people who've been in school before and the like. But I think the Delta variant is a key element to that. I mean, we were always worried that this would happen in kids. When they got into school, it would be a real transmission chamber and it would funnel up the cases dramatically. And then, of course, a certain percentage, even though it is lower than adults, would end up with more significant disease, either the MIS syndrome or hospitalization with actual COVID-related disease. And so I think that the Delta variant just being dramatically more contagious than the previous variants has made that closer to a reality than thankfully it did the first time. So I think that all by itself is a big part of the situation. And clearly we have, as a society, become less worried about the virus. Not to say that's appropriate, but we certainly have. We've become used to it, if you will. We see, more people dying of it now than we have ever seen. But it seemingly that gets less attention than it used to, just from the average person out there in the community. We become a bit numbed, I think, as a society to it. Kids wake us up from that numbness, I think, a lot. When kids get sick, people appropriately pay more attention to it. And we certainly have seen, as you say, a dramatic increase. Whether or not the virulence of Delta is spreading that much to kids, I think is harder for me to know. I'm not seeing great data that, the data that I mentioned before was a British study with 40,000 or so cases of Delta variant. And compared to the Alpha before it, it was about twice as virulent. And that really agrees with some of the preliminary data on Delta that came out of Scotland that showed twice the hospitalization rate early on, and that was a bit early at that point. We weren't sure, but I think that's kind of borne out. So you take a virus rather that's twice as contagious, up to twice as virulent in any population, even though the kids are relatively protected compared to adults. And then you take a situation where we're not as worried about it. I think we were more careful in the way of some situations at school at first. Now, obviously, with everybody being masked, I think that'll make up for some of that. But I think all of those things come together, and you need at least two or three of those together to really get this increase in cases of kids. So what we are concerned about is the kids, obviously for their own safety, and then also when you see that transmission, even those who don't get as ill from it, they are, with this more contagious virus, probably more effective at transmitting it through families to other adults who are unvaccinated, unprotected, or maybe even just more at risk and don't get the protection from the vaccine if they're immunosuppressed or maybe even elderly at this point. So as I think we mentioned before, it used to be with the other variants that you would have somebody in the household and you could stick them in their room and have a decent chance of other people in the household not getting it. That is not as common with this Delta variant. I mean, all too often, because I do monoclonal antibodies, and I very frequently get calls from physicians or other healthcare workers and say, "Hey, I've got this, and my spouse has it, and our two kids have it, and I mean everybody but the pet has it." And so we're just seeing a lot more widespread transmission in the household. So obviously the kids, in addition to being very difficult that they're sick themselves, also probably are having a higher transmission to the families. And that's why we're not quite, optimism. We have a little optimism based on the cases not just continuing to spiral upward, but I think the kids in schools, we've seen a lot of transmission, obviously, and that's been part of the genesis for some of the cases of kids that are sick. And that's not over yet. I mean, there are plenty of unvaccinated kids that have not gotten it. Obviously, everybody under 12. And so the thing we need to do is we need to surround those kids with vaccinated adults and vaccinated older kids. Is one key way to protect them, and then also to do those common sense things that we know. Try not to cram them together as much as we can. Do activities outside when you can, and obviously have masks when they have to be close together.
And one follow-up on pediatric cases. I don't know if this is something you can speak to from personal experience or just from talking to colleagues and reading. Are there trends among the children who get very sick enough to require some type of treatment or hospitalization? We know among older patients, people with comorbidities are just more likely to get really sick. Are children with diabetes or children who are obese seeing more severe illness than other children?
Yeah, I think it in some ways, because I do see kids here as well, and so my experience has been, I would say, sort of similar in the kids as what it has been adults. And I don't know that this translates into all the national trends, but I would say certainly that obesity remains something that's very important. I mean, a kid that is significantly overweight has been more likely, in my experience, to get sick from COVID, just like adults have. And I think sometimes it's interesting when I talk about this in various venues. Occasionally, there's the criticism that, well, you talk about, what medicines to give and monoclonal antibodies and all these high-tech things, but you don't ever mention that you need to exercise and try to keep your weight down, and those other things are very important. And they are. There's no question about it. I think those remain important risk factors. But make no mistake, some people mistakenly say, "Oh, well, if you eat right and exercise, and your immune system will do the job." No, I mean, thousands upon thousands of people die of the flu and sepsis and other things every day from infections with perfectly normal immune systems who exercise. So it's not the case that your immune system protects you from everything just because you do your job to have a more healthy lifestyle than your next door neighbor. It does not work out that way. So I think I have seen more recently, and maybe this speaks to the virulence increase of the Delta variant, but we have seen more people of late, both kids and adults, who are in good shape, normal weight and the like, to get really sick from COVID. So we've seen more of that lately than we saw before. So again, I'm very sensitive to the fact that it is true that those other comorbidities do play roles, and they have played important roles along the way. But I think they play less of a role today than what we've seen in the past, and it would be a very, very bad mistake, as I see sometimes somebody saying, "Hey, I'm in good shape and I'm relatively healthy and relatively young, so I'm not going to worry about getting the vaccine or doing other things to protect myself." I have seen people die proclaiming that when they came in the hospital.
Well, thank you. It's an unfortunate note to end on, but thank you for your answer.
Yeah, absolutely. Thanks. Any other questions? Got a couple from the feed that I'll try to answer briefly. See, Rose Locke asked, for those who've been getting vaccinated and still getting infected with a breakthrough case, is there one vaccine that's showing up? And that's a good question. And I would say no, in that there's the problem that the majority of people have gotten the Pfizer vaccine in this area, like it really has been the case throughout the country. So when you're looking at something that when the majority of people who were vaccinated got the Pfizer vaccine, and it's a rare event for somebody in that situation to land in the hospital as well, it wouldn't be a surprise that most of those breakthroughs are going to be having in people who've had the Pfizer vaccine. But I don't think there are any national trend data that is the case. In fact, of course, there are some data that the other vaccine, the Moderna vaccine, had fared a bit better against Delta than Pfizer did in some of these situations. And some of those data are hard to shake out. And it's also important to know that that when you look at these variants, they don't descend from one another. They spring off independently. So it might not be the case that the next variant would even have that same characteristic relative to the two vaccines. But we haven't seen any major indication that one vaccine is much more likely to land you in the hospital with a breakthrough compared to other ones. And here's a good question. Randy Higdon asks, why don't please give some information about pre-hospital care to keep people out of the hospital? And that's a very important point. And just to summarize very briefly what we see and what I think about that, the things that I tell people when they call and say, "I've got COVID-19, what do I do now? I'm not immunosuppressed, and I don't have any. I'm not overweight. I don't qualify for the monoclonal antibody. What can I do?" And the things are sort of simple. There aren't many really. The first is to sort of stay hydrated. Because I think most of the people that land in the hospital end up dehydrated before they get there. And that's just that there are several things that lead to that. You may cough and sneeze and lose fluid more than you normally would, so-called insensible losses. We call that kind of in medicine. And then also a lot of people have diarrhea and they lose fluid that way too. So a lot of people end up dehydrated, and that may not be causative to their admission, but certainly it's helpful to try to stay hydrated in this situation. And the other thing is just to kind of stay as active as you can. Obviously, if you're short of breath, you can't move around that much, but it's helpful not to take to bed and stay there. That causes decongestioning much faster. It even can predispose to blood clots, which we know can be sort of associated with the COVID illness as well. What things are sort of neutral? I think they're the zinc, vitamin C, vitamin D. A lot of people get very emotional about these things. But if you look at those vitamin therapies, the National Institutes of Health database would suggest that there's no evidence that they are helpful. And I think that is true. There are no good studies that show that taking the vitamins that have become popular with this really have any statistical advantage. There are no clinical trials that show that they're beneficial. Probably don't hurt. I certainly have no objection to people taking them at all. When you look at vitamin D, several illnesses that seem to do worse with COVID-19, obesity, older age, and other conditions that can have low vitamin D associated with them also have that lower vitamin D. But that's a different thing from saying that taking vitamin D then actually corrects that or prevents that. We don't really know that at all. And so those things are sort of neutral, even with zinc, which kind of works in some of the rhinovirus common cold trials to lessen severity of illness. But you had to take enough of them to make you nauseated to do that. So, the choice is yours on that one. So I think they're sort of neutral. But then finally, importantly, and again, I don't want to give anybody specific advice because they need to check with their healthcare provider about these things, but steroids, like Medrol dose packs, are things that many people are taking right now to try to prevent some of the symptoms of this disease, and that is not a good idea. They're very clearly recommended against if you are early in disease and your oxygen is normal. And so if your oxygen's normal and you're feeling, and you're breathing okay, it's a poor idea in general for somebody to be taking steroids, with the exceptions that you might have asthma, severe asthma and wheezing. In those cases, okay, maybe so, your physician may do that. But if you get prescribed a Medrol dose pack routinely for COVID-19, I mean, you should actually ask your provider, okay, is there a reason for my lungs that I need the steroids, or because the NIH guidelines and others would suggest fairly strongly not to take those steroids. And then just as the sideline to that, getting a good oxygen monitor is going to be the important way to monitor yourself, because if that drops into the low 90s or upper 80s consistently, you need to start talking to your healthcare provider about packing up and heading toward the hospital to get some oxygen to then get the steroids, because once you get that advanced problem and the oxygen drops, then steroids can be helpful. So it's a bit confusing in that regard. And then one final thing, just taking antibiotics in general, a Z-Pak or azithromycin is very commonly administered to people who have early COVID, and it has no antiviral activity. There may be the case where your physician may think that you have a bacterial infection on top of it, and if so, fine, but that is sort of uncommon, and it shouldn't be given as just a routine sort of therapy for somebody with COVID-19. And of course, again, the monoclonal antibodies, if you are in any of those conditions, over 65, pregnant, sickle cell disease, diabetic, immunocompromised for any sort of situation, or any overweight or obesity, a BMI of 24 or higher qualifies you to get the monoclonal antibody as an increased risk condition. That's not very much. I think I figured this up the other day. If you're 6 feet tall, it's 185 pounds. If you're 5'6", it's 155 pounds. So it's not uncommon to qualify on that regard as well. So if you have any of those conditions that increase your risk, it's definitely worth a call to your provider to see if you would qualify then for the monoclonal antibody. It has to be within 10 days of the onset of your symptoms. So there's some other sort of stipulations that the emergency use authorization has made, so we make sure we're giving it to the right people. But for heaven's sake, get the vaccine. I mean, people, I've seen all too many people say, I want this monoclonal antibody. They run in to get it, but they didn't bother to get the vaccine. And though I am a believer in the monoclonal antibody, and we may have been the first people in the country to give it at our clinic that I'm sitting in right now, because we built out a facility that you could do that, the data for that, though I believe in them, are dramatically less impressive than the data for the vaccine. So much better just to not put yourself in that situation where you even need to do that. A couple of other questions I'll just read here. Well, this is interesting. It's a pair. Randy Hagan asks, why aren't you using hydroxychloroquine and ivermectin? And immediately after that, Leanne McIntosh asks, why are doctors prescribing ivermectin for COVID? So that kind of sums up, I think, the situation we're in very quickly. Actually, because I answered this question so much, I did a YouTube video on the topic of ivermectin. I think that without going over all of that in exhaustive detail, ivermectin, there are two reasons to think a medicine might work. Test tube data, or so-called in vitro data, And then there's clinical trials data or in vivo data. And with the test tube data, yep, you can get ivermectin to inhibit virus replication, but you have to use many times the concentration of ivermectin that have ever been tested in humans to make that happen. It's not saying that some people couldn't tolerate that dose, but a lot of times they can, and it's certainly never been studied to be safe in that dose. So you can interfere with viral replication with anything if you give it in a high enough concentration. The problem is that concentration also inhibits human beings, and that therefore is the problem. And for people to take their sort of horse medication, ivermectin medication for that is a really bad plan. With the in vivo or the clinical trials data, there have been a couple of really good clinical trials, and they have shown no benefit. There was a very bad clinical trial that was pulled off of the preprint servers because there was all manner of plagiarism, and they were counting people who died before the trial started. It was an Egyptian study that was quoted as being the successful trial, and it was very successful. The problem is it just wasn't true. And so there really aren't any good clinical trials data that suggest that ivermectin works. And for that simple reason, we don't use it. I have no connection to any company or anything related to competitors of ivermectin. I used ivermectin a couple of weeks ago on a heart transplant patient that had a strongyloides parasitic infection. We use it with some frequency there. So I have nothing against the drug. I just don't want to give a drug in a situation where it doesn't help. Let's look. Kim Rierick asked, will the infusion help if it's been longer than 10 days from getting COVID? And that's indeed one of the stipulations about the monoclonal antibody therapy. It needs to be less than 10 days duration of your illness. If you haven't had any symptoms and you were tested positive and are at really high risk and someone wants to pursue that, that would be the 10-day mark there. The only reason for that simply is that after 10 days of illness, you're really not likely to be benefiting from additional antibody. You're moving into that phase of the illness where the virus has kind of gotten the upper hand or not. And sometimes if you're not making enough antibody fast enough in that race, you can then move over into that stage of the disease where the body accidentally and mistakenly attacks our own lungs and participates in that problem. That's part of the reason people get so sick and have to be put on ventilators. And so it just seems that that monoclonal antibodies or antibodies being administered don't really do a lot of good after that. We saw this in actually some of the convalescent antibodies in sera that we were giving people. There was some regional data early on, but it turns out globally it didn't help very much. I think if you really did that study really early on, it may very well have been the most effective when you look at convalescent titers. And the same thing is true by the same token. They're all antibodies we're talking about. So the monoclonal antibodies would really be in the same situation. I think that's all I have from the feed. Any other questions I can answer?
Yeah, I had a quick question. This is, go ahead.
Yeah, good.
Oh, no, you go ahead. I'll ask after.
Yeah, just really quick. This is Ariana with Channel 5. When looking at the numbers released from the Shelby County Health Department today, it looks like this is the highest daily COVID-19 case count we've seen since December of 2020. Do you think this is a result of some of these Labor Day numbers coming in, or is there anything else that you might attribute that to?
Well, it's probably a bit early for that to actually have been the transmission point. Now, it could simply be that people were around a lot of family members or went on trips and they decided to get tested. That could be what's going on there. I think it's probably now with the caveat that Delta seems to have a shorter incubation period than some of the ones before. It may run the course into the actual clinical infection faster than some of its predecessors. But I think it's probably a little too early to say that this is a run-up due to Labor Day activities. Probably a little bit early for that. But again, maybe just be the people who tested more after getting back and they found infections that they already had and unfortunately may have spread through the Labor Day holiday, and then we won't see the results of that for another few days. But if things really do continue to take that cycle of cases followed by hospitalizations followed by death, and that kind of I hate to hear that. I had not heard that number from today, and so that's obviously concerning. Day-to-day variation can vary a lot. That's why we do kind of the week over week average. And then also, I think the best number has always been, or most consistent number has been the hospitalization number. And though they have kind of pulled back from the from the peak, they haven't pulled back that far. And we're still in a very vulnerable situation from the standpoint of hospital and ICU utilization. And it's kind of, it does make you feel bad to hear that the cases are on the up again, because, you know, as things follow each other in a typical course, a week or so, 10 days or so after the increase in cases is when you would typically see the increase in hospitalizations, because it just takes that long for people to become really ill. The death curve on COVID-19 in the Delta era here has been a bit protracted, because in the earlier versions, elderly people would get the disease and they would come into the hospital and unfortunately would succumb to that infection quite quickly. And so the deaths followed quicker after the infection than what we are seeing now. I've got an ICU full of 30s and 40-year-old people who remain on ECMO or artificial lung technology or the ventilators or all these things. And so they will be in the ICU for sometimes months, literally. And when they fail to survive, that can take a long time for that to happen. And we certainly do everything we can in those situations, just like we do at every age group. But so I think that we've seen several deaths over the last week or so that kind of are reflecting the increased number from weeks ago. A lot of the people had been in the hospital for some time. So yeah, that makes me concerned, as always, to hear the numbers are up. Hopefully that's just a blip from people being tested, but it's something we have to watch out for. As I'm fond of saying now, the one thing we should have been cured of by now with COVID-19 is overconfidence. And even as we were celebrating last time when our number was 10 in the hospital here, down from 172, we were about to push into normal life, as was appropriate, but Delta was on the doorstep at that point and causing some havoc in other countries, which is why we have to watch out what's going in other countries too, and not fail to vaccinate people in other countries, because these mutants and variants that we read about, the mu variant, the gamma is still out there circulating. They can all become next week's problem, because we've gotten a lot of increase in transmissibility, contagiousness of these new variants, and that's really what's driven them into kind of the top seat of 99% U.S. cases of Delta. But the next step in that evolution might not be still more contagious. You can't get a whole lot more contagious than what we're seeing. We're already up among the highest transmission rates of any infection we've ever known with this Delta variant, or at least pushing that envelope. But it may be that we move into the slipperier virus becomes the winner rather than just the fastest, because as more people have immunity from Delta, both from vaccine and from natural infection, and both are helpful, quite helpful. It may just be that the next variant, Gamma was famous for this. It's how it made its name in the first place. Mu has seemingly the mutational potential for this, though we don't have enough clinical data to know whether it will really behave that way or not. But those things could end up being more evasive of our immunity, both from the vaccine and natural infection. And that may be how the next variant, if it does, sweeps in. We hope not, but that's what we have to watch out for as we look at these new variants. And it's why we continue to monitor worldwide and nationwide about what variants we're seeing and sequencing some of these things to have a heads up when that's happening.
I'll jump back in with one more question I forgot to ask earlier. I'm sorry. So this was a question from a reader I got. A woman emailed me. She is a doctor. She has some colleagues who are working in Nicaragua, who were only able to either get the Covishield or the Sputnik vaccines. They would like to either now get Pfizer or Moderna. They want to know, is there anything preventing them from mixing the vaccines, so to speak, and do they need to wait a certain amount of time?
Yeah, great question. And of course, again, caveat, everybody's different, so I don't want to give any sort of individual advice on that, but we don't know the answer, of course. There's just no study. The only way you know this sort of thing is to do a good clinical trial. The closest thing we have to that would be some of the British data where they had given the AstraZeneca vaccine, which is closer to kind of the J&J, a non-RNA vaccine, and then followed that with a Pfizer. And those people did very well, gave very good antibody boosts. And so that really lit up the possibility of mixing the vaccines. It's never really been recommended to do that here. Why? Because we have plenty of vaccines to give. And why try it? Why do your own trial of one? I mean, when we know something works to give the same vaccine, obviously it's better to do what's been studied widely. All of that said, the Sputnik vaccine, for example, has done reasonably well in some of the numbers. They didn't do a very good job of publishing their safety numbers early on, and some of the Chinese vaccines had been highly variable. So, where this came in a practical standpoint for me is in talking to several colleges. What do you do in schools that mandate the vaccine, but they received vaccines in another country that might not be FDA approved, and even or how to deal with that? And so, kind of, I think having WHO approval, World Health Organization approval, stands in some benefit there too. But I think a lot of people really will just have to repeat the vaccine with an FDA approved vaccine simply from a logistics standpoint, because some people locally in the US won't recognize that vaccine. So I would say that there are no data to suggest that that is a problem to do that. There are no data that suggests there's any danger in doing that. I would probably wait the prescribed time I would between any of those doses for the first one. So usually that's not very long. Out to 3 months with the AstraZeneca, people began to wait for those. But it's certainly reasonable to push ahead if you've had a non-FDA approved vaccine to then pursue one of those. Usually that's done with the RNA vaccine, because the other ones outside of FDA approval are not RNA vaccines. So in that sense, we know that an RNA vaccine on top of one of the other type vaccines has been shown to work in general. It just hasn't been shown to work in many specific examples. So I think a lot of people will end up having to get an RNA vaccine on top of those other types of vaccines, particularly if they're coming back to the US from another country. And again, there's no reason to think that it would be dangerous based on any data that we know so far. Any other questions? Okay, thanks guys. Have a good weekend.